Hi, my name is Melanie, and I am your IVF nurse. Today's topic is going to be about moving from doing timed intercourse cycles to insemination or IUI cycles, as some of you may know it. So, what is an IUI? An IUI is, or what was once called, artificial insemination. So, what the doctor is doing, or the nurse in some clinics, is taking the sample provided by your partner or by a sperm donor, and the lab prepares it so that it's suitable to go directly into the uterus. And essentially, that's what the doctor or nurse is doing, is taking a catheter and inserting the sample in past the cervical os into the uterus to increase the chances of pregnancy. Now, usually the first 3 or 4 cycles of timed intercourse, if it's not successful, the doctor may talk to you about stepping it up a bit and doing some inseminations. Inseminations can be done with or without medications. Sometimes it's done on a natural cycle where most likely you're only going to release 1 egg. There are other medications called Clomid, which is commonly prescribed by family physicians, or your OB-GYN. Fertility specialists are using it. However, more tend to be going towards the use of letrozole or Femara. And what ends up happening is that the use of those oral medications, because they're only taken for approximately 5 days of the cycle, and it can vary from clinic to clinic. So it may start on your day 3 and you're taking it till day 7, or some clinics may say start on your day no later than day 5 going to day 9 of your cycle. There is monitoring involved in this as well when you start taking oral medications, because they want to know in terms of the number of follicles that you're going to have at the time of ovulation. So they want to track to reduce the risk of multiples. So if you've developed many follicles, and some people are very sensitive to the medications and may produce maybe 2, 3, 4, and the doctor may have concerns that there are multiples at the time of the insemination and may choose to cancel the insemination. Now, some patients who've done a few cycles of inseminations or IUIs, or TDI, the therapeutic donor insemination, they are not successful, then your doctor may discuss with you doing low dose stimulation with the use of either Gonal-F or Puragon at very low doses. And this will help to increase your chances of having multiple follicles, or potentially 2, maybe 3, to increase your chances of pregnancy throughout the insemination cycle. So what happens is that with a low dose stimulation, the use of Puragon or Gonal-F, what would end up happening is that you're doing daily injections, which could be as little as 25 units, 37.5 units, or 50 units, depending on age, maybe even 75 units. And then you're coming in more frequently for monitoring to see if the doses need to be adjusted as you near ovulation. For those of you that do not ovulate, there are medications that are used as well. Those would be called Ovidril, and that's a subcutaneous injection at the time when your follicle size is appropriate and your hormone levels are saying that you should be nearing ovulation, and your body may just need that final push. So there's Ovidril, which is a preloaded pen. There is Pregnol, which is a powder that needs to be dissolved. And then there's the use of HCG. Use of HCG and Pregnol is primarily used in IVF cycles. However, it may be used, depending on your doctor or clinic, for an insemination cycle. Now, with the risk of inseminations, obviously if you have more than 1 follicle, you have the risk of multiples, which your doctor would speak to you about. The other thing is that using either Clomid, letrozole, or the low dose stimulations, you may have a risk of ovarian cysts that could be residual from the previous cycle of using the medication, abdominal pain, pelvic pain, hyperstimulation for those of you that are very sensitive, bloating. Some people, because of the hormones, may feel sick, headaches, diarrhea. In severe cases, enlarged ovaries, fluid in the abdomen, difficulty breathing. Those are kind of more symptoms of OHSS or hyperstimulation, which aren't commonly seen in insemination cycles. However, it is it is something that the doctor needs to be considering when monitoring you throughout the cycle, and if you are one of those that stimulate excessively with low dose FSH. Now, the other thing that's important anytime you're introducing any medications, because they're hormones, is there's always the risk of blood clots in circulation. And then if you're having any symptoms that you think are not normal or what your clinic has advised you, it's always good to check with them or check with the nurse to see, is this normal? What can I do? The other thing is, with an insemination, it does increase your chances by about 8 to 10% over that of timed intercourse. Now, how it does that is that, like I had mentioned before, when we're putting in the sperm into the uterus, it's bypassing the cervical mucus, it is bypassing the cervix itself and everything in the vagina, because when you're having timed intercourse, when your partner ejaculates, everything sits in the vagina, and then it's left up to the sperm to penetrate through all that cervical mucus at the time of ovulation, and then swim up to the uterus, or up through the uterus, and then hopefully finding that egg once it's released. Now, with the inseminations, they are timed with your ovulation, or if we've triggered you. So what ends up happening is that we will have the sample prepared by the lab, and the clinic that you're working with will give you your instructions that you need as to what time to drop off the sample. If you've got donor samples, any documents or paperwork you need to sign as well. And then what will happen is that once the sample is ready, the nurse will go through your instructions with you either before or after the insemination. In some clinics, the nurses do the inseminations. Other clinics, it may just be the doctor. So what's happening is that the sample is drawn up into a syringe that has a catheter on it, and then what will happen is the nurse or doctor will insert a speculum into the vagina, and from there they will take the catheter that's attached to the syringe with the sperm sample in it and go through the cervical os. And then once they know that they're in, and the catheters, they are marked so that they know how far to go in, and then some people just have a natural gift and know exactly where to go in, or how deep to go into the uterus. So what ends up happening is that the sperm is then deposited into the uterus, the catheter is then removed, as well as the speculum, and then what is next is that usually you rest for about 10 to 15 minutes after. So just so you can take a look at what we're actually doing, I'm going to show you a quick picture. So this is a picture of what the uterus and your ovaries and fallopian tubes look like. So this would be the catheter here. So this is your cervix, and then what ends up happening is that the catheter goes into the cervical os. There's the external os, internal os, and then you're going past that and then up into the uterus. And then you're depositing the sperm, and as you look, you can see in the diagram it shows that there are little speckles, and the sperm should swim through the fallopian tubes to meet up with the egg that's being released. So that's what the insemination does, as opposed to just having timed intercourse where the sperm is deposited only in the vagina here. So that's why you're getting about an 8 to 10% chance increase in insemination over that of timed intercourse. Now, some doctors may describe that your statistical chance in becoming pregnant is about 80%. So this is usually timed over approximately 4 cycles. And if you're kind of unexplained and everything looks good on paper and you should be ovulating, what happens is that they may quote you and say, oh yes, 80% chance this will work for you. So you break it down so that by the first chance, yes, you're thinking, oh wow, this is great, I have an 80% chance. But usually it takes maybe 2, 3, or 4 inseminations, if an insemination is going to work for you, in order for it to be effective. It's not effective after 3 or 4 tries, then the best thing, what I always recommend to patients or anybody going through infertility treatments, is to sit down with your doctor and see what the next step would be, and if you need to be doing something a little bit more aggressive to get things going. I hope that explains to you about the insemination process. Good luck to those of you that are in that process as well. Thank you for watching. My name is Melanie once again. My email is yourivfnurse@gmail.com. Please feel free to send me an email with any questions you may have. The other thing as well, please feel free to check out my website, www.yourivfnurse.com, for any additional information that you may have about my services that are available to you. Thanks for watching.